Okay. Good evening, everybody. After dinner is the perfect time to talk about our subject. We are going to give you some food for thought. So my name is Cherie Aguilar, and my fellow peers, Pabitra, Sharma, and Mushinky, were all part of the Family Nurse Practitioner program here at Carlow University. Wanted to go over some stuff. There's a lot of Mediterranean diet studies out there. So we wanted to see if there was a correlation. We wanted to see if there was a correlation with the Mediterranean diet with the level of burnout in our fellow Carlow nursing graduate students. We wanted to investigate a possible correlation between the intake of the Mediterranean diet and the subjective level of burnout in nursing graduate students. The purpose of our study, as a graduate student, we don't know stress, to improve healthcare by adding to the body of knowledge concerning the possibility of a link between diet and emotional well-being. A little bit of a background. In the United States, 659,000 people die every year in the United States from heart disease. That's 1 in every 4 deaths. The Mediterranean diet is the preferred diet in the healthcare world. It is the most studied diet with lots of literature on its benefits. But a lack of knowledge from the people and healthcare professionals is the problem. Okay, practice what you preach. What is the Mediterranean diet? Mediterranean diet, monounsaturated fats and polyunsaturated fats. The main source of fats in the Mediterranean diet is olive oil. You use olive oil instead of butter. Omega-3 fatty fish such as salmon, albacore tuna, nuts such as walnuts, almonds, and hazelnuts, legumes. What does a meal consist of? Mostly you're going with whole grains, beans, and vegetables. Whole grains being whole wheat bread, whole wheat pasta, brown rice, oats. Beans such as chickpeas, kidney beans, fava beans. Vegetables. And the main feature of the Mediterranean diet is tomato and garlic or onion sauces. And for dessert, fresh fruit. That's a shocker, right? There's some pictures of some of what your plate should look like. Okay, some of the studies that set the stage. The first study we have is the PREDIMED. It was done between 2003 and 2011. And it studied the metabolic syndrome and cardiovascular disease with the Mediterranean diet and showed lower risk of cardiovascular disease. In 2019, the Spanish study with college students, there was a positive emotional state with Mediterranean diet consumption. In 2021, there was a cross-sectional study of college students, which showed a Mediterranean diet associated with higher GPA scores. And in 2022, there was a non-adherent study to the Mediterranean diet, which showed a low consumption had more test anxiety and poorer performance. With our study, we used a cross-sectional questionnaire utilizing mixed methods. Our study is a correlational descriptive study using mixed methods of quantitative and qualitative variables. We used the convenient sample and was voluntary with Carlow nursing graduate students. We obtained our IRB in the fall of 2021 through Carlow University. Some of the tools that we used, we had an informed consent for them to sign, and we had a Mediterranean diet questionnaire. We also had an abbreviated mass-latch burnout inventory scale. We used a non-parametric measurements for our statistical analysis. Our PCOT format. Our population was nursing graduate students at Carlow University, including both first year and second year students, so up to 1 semester post-graduation. For the I, we used a quantitative number of Mediterranean diet items consumed. And the C for comparison, compared intake of the Mediterranean diet and burnout. And the outcome, Mediterranean diet can prevent professional burnout. The time frame we used was 1 point in time, spring 2022 for 3 months. Ethical considerations, we really didn't have any. Literature review, when we did our literature search, we used EBSCOhost CNOW, PubMed, Boolean search models. And we used the results within the past 5 years, except for the landmark PreDiMed study. We used scholarly review journals only and full texts. Pavi is up next to discuss our methods and findings, and thank you very much.
Thank you, Cherie. So I'm going to get started with the methods. Like Cherie, my colleague said, the main aim of our study is to see correlation between Mediterranean diet and burnout in professionals like nursing. So the research took place in Carlow University students at Carroll campus. Criteria was that participants had to be above 18 years and then below 65, and participants were randomly selected. So we began our data collection at the beginning of March, and we started with the classroom setting. We only got about 10 total. So we did ask our faculties and then ask them to help us with the online link setting up. And thanks to Dr. Foreman and also thanks to Dr. Good, they set up a link for us online for the graduate students. And then we were able to get 24 more participants. Our aim was to get at least 30, and we did get 34 total. And we were satisfied with that. And then we stopped at the end of March collecting the data. The dependent variable is the burnout section in the survey, and the independent variable is the diet. So this is the tool that we use for measuring the Mediterranean diet. It had 14 questions altogether, yes/no questions, and we only counted the yes portion, and the no we didn't count it. And Cherie explained already, the different kinds of Mediterranean that we focused on, mainly fruits, vegetables, and whole grains. And also there was wine in that section as well, which was supposed to be good.
Wine makes everything better.
The burnout section was evaluated by using the MBI scoring tool, and this one had 9 questions. It's an abbreviated one, and it had 3 sections: personal accomplishment, depersonalization, and emotional exhaustion. The scorings were counted manually and then added up in a table. I'm going to show you the table later in the presentation. So analysis, we used from the Staplet website, we use correlation testing data analysis, and we compared that with Mediterranean diet with personal accomplishment, depersonalization, and emotional exertion. And now we also created a pie chart showing how many of the participants scored low, moderate, and high in the diet section. I'll show you the chart below. Sorry, we didn't make it too fancy, but this is the participants list. So 1 out of 34. And as you can see, participant 1 scored 11, which is about pretty high consumption of Mediterranean diet, and 34 scored 8. So those are the numbers. If we put it in the pie chart, as you can see, 10 were the participants who scored the highest, who consume their Mediterranean diet on a daily basis, and 6 scored moderate, and 18 of them scored low, meaning that more than 50% of our participants do not consume Mediterranean diet in regular basis. Next one is the scoring for the burnout. And on this one, it's all manually counted. So out of 34 participants and their scorings on, first one is the personal accomplishment, second one is, let me show you, I think I'm just focusing there. Second one is the depersonalization, and the third one is the emotional exertion. And how we did was we put that into scatter plot chart, and then did the data analysis to get the correlation. On the first one, we got for personal accomplishment, we got R value, which is the correlation 0.142, meaning that there is a slight or a weak positive correlation of consuming Mediterranean diet with the personal accomplishment or doing something good at work. And these are just the plots of the participants, all those blue dots. And next one is the chart, correlation chart again for the Mediterranean diet consumption and the depersonalization. And we could see that the line is facing down, meaning that there is a negative correlation of depersonalization and Mediterranean diet score. So the more we consume, the less depersonalized we were, and the less we consume, a little higher rate of depersonalization. Same with the empty diet and emotional exertion. We got R value of minus 0.201, showing the line going down towards the negative side. And for the summary, I would like to invite my colleague Bob for the introduction.
Okay, folks, so here's the fun section. What does all of this mean, basically, okay? So first off, half of our participants utilize the Mediterranean diet. That's not surprising, being we're so busy and so active. You know, we're graduate students, we work, we go to school. So that's not surprising. So basically, we did find a weak correlation between the intake of the Mediterranean diet and burnout. And also too, correlation studies, they show relationships and they hint at it, but it's very important to know they don't show causation, okay? So it's a cross-sectional study, so it can show correlations, but not causation, okay? So the strengths of this study were, it's cross-sectional in nature, it's, you know, it's one time and people just answer one time, okay? And the graduate students were there, so well, it's a convenient sample, so it's easy to find people. And there were very few, if any, ethical concerns because it's just filling up questions on a paper. It's not like you're doing experiments on these people. So the results. Okay, so first off, R is the correlation coefficient. So what that means basically is it shows correlations between variables, okay? So that the intake of this diet, that was the independent variable, and the burnout was the dependent variable, okay? So actually it showed a very weak correlation, okay? So R was 0.142 for personal accomplishment, and that was a straight, you know, positive relation. So there was a very weak inverse relation for burnout with the intake of the Mediterranean diet with depersonalization and emotional exhaustion, okay? So like 0.2, it's something, it's not that much though, okay? So basically a strong positive correlation is above 0.7 and a strong negative is below 0.7, so yeah. So basically we did expect a stronger correlation between people that have a high intake of this diet on the negative aspects of burnout, okay? But there's more. So I call this section olive oil gate, or, oh wait, I'm sorry, that's 2 slides away. I'm jumping ahead. So limitations to our study. So the R2 value, that's basically the proportion of the variation in the dependent variable burnout with the independent variable, which is intake of the Mediterranean diet, okay? That was fairly low, once again, at 0.02, 0.04, and 0.04. So there wasn't a real strong correlation. And also too, our standard deviation was a bit high. So what that says is perhaps our convenience sample, you know, wasn't truly, you know, showing on people in this population. It wasn't the best representation of people. And the thing is most people in this study were female, white, and below 30, you know? So that could be why. Here's my favorite section, okay? So the olive oil controversy. So what's fun, it's sort of funny, basically. So recently, the PREDIMED study came out, and they said that there's probably a correlation, but not causation, with higher intake of this diet and good cardiovascular health. And this is kind of funny. So the reason is a lack of randomization. So basically in this village in Spain, they had two groups, control groups and the group, getting the intervention. So people in the control group complained that they weren't getting free olive oil. And so this, guy, doing the study was like, I'm sorry, I'll give you all free olive oil. Well, you can't do that to both the control group and the intervention group, okay? So what's kind of weird is as nurses and physicians and teacher NPs, we base our teaching on something, and it's kind of funny that something like this happened in this major study. So what this means is they did redact part of the PREDIMED study, and they did say that perhaps, there isn't that strong of a causation, with good cardiovascular health as we once thought, but there is some correlation. So there is something to it, okay? And that sort of ties in with our findings, basically. I'm not saying, this is some airtight study, but on the same token, it's kind of odd that we found a weak correlation and they found one as well. So, and anyway, so suggestions for the future, for future studies, I would say probably having more, randomized controlled trials in the future on this topic. And like I said before, our study seems to show a slight correlation, but not causation between intake of EMD and feelings of burnout. So, are there any questions? I'm sure there are. Yes.
So you talk about burnout, and so how did you choose what you were going to define as burnout? So you looked at depersonalization?
Yes. Yes, emotional exhaustion as well, and feelings of accomplishment. Just because we couldn't, give people the entire mass/burnout inventory. It's so long, but the abbreviated version does, it's valid. Basically, was proven valid. So we used those parameters for burnout.
I mean, was it studied with just the 3 parameters, or?
We
not?
It was 9 questions, but they showed those parameters. So like, how do you feel at work? Do you feel, exhilarated after work? Do you feel like you treat your patients like objects? So each question, correlated back to an answer on the scale. Anything else? Really? I'm surprised. This is fascinating. Yes.
Nice job.
Oh,
What
thank
would
you.
you do differently next time or change?
If we had more time, I think I would have liked not doing cross-sectional, maybe. I would have liked having the time to just randomize people. I would also like going to some more universities, getting some more guys, people of color in this study, because everybody was basically like 26, a female and pregnant. No pun intended. Bing bang.
However, you had to make your own diversity.
We did. And what's so funny is some people I think were embarrassed, with their answers, and they said, I'm not a serial killer, I promise. It's kind of funny. But I just find this whole olive oil thing just hilarious. I picture a guy in Spain saying, I'm so sorry, here's your olive oil, it's kind of funny.
Tell me again the number in your sample.
We had 34.
So if you're going to do anything further, you want to have a larger sample.
Oh, definitely,
So anytime you do any of the statistics, you have to make sure that you're going to get which I'm surprised, but I think everybody that has done a little bit of their
Oh, definitely.
stats over the last term has found that. But
And the p-values were sort of
Exactly.
non-existent, but we couldn't
you
help
can't
it.
you can't draw any conclusions.
But it was really hard to find people, though, on the same token. It was hard to find people. I was surprised, even online.
Yeah. Oh yeah.
We'd hey. Anything else, guys?
It's fine.
Marcia pulled up Savannah. It might be on the PowerPoint. There. There's one.
You guys see if I'm standing here?
Yeah.
Okay.
You're not that tall, buddy.
Hi, I'm Savanna. Sorry I'm late. We are assessing mental health literacy in undergraduate college students. I'm Morgan Fisher. I'm Andrea Carroll. All right, so I'm going to start off with our introduction. So basically, to kind of say why our topic is so important and why we chose it, is that 1 in 5 adults in the United States suffer from a mental illness, which equates to 20%. 1 in 3 college students meet mental illness diagnostic criteria, so 33%, which is a very high amount. We're seeing a rise in students attending college with pre-existing mental illness, and college students are more likely to identify depression versus anxiety, and they're more likely to associate their symptomatology with stress. 64% of college-age students with mental health problems have not sought professional help in the last year. And we were seeing through our research that this is creating a lot of disparities in recognition and treatment of these mental illnesses in this patient population. So research suggests that college students have limited knowledge regarding mental health disorders and where and how to seek help. So although research largely demonstrates that individuals can recognize mental health disorders, like I said previously, they were often seeking self-care because they thought it was just stress, which I think a lot of very high-functioning individuals do. So we decided to dive a little deeper into mental health literacy, which is defined as knowledge about mental health disorders that are associated with recognition, management, and prevention. So higher mental health literacy, we were finding through our research, was allowing people to quickly identify their symptoms and then seek prompt treatment, which is the overarching goal of what we want to do as primary care providers. So education on improving mental health literacy includes stigmas, options for treatment, recovery statistics. We wanted to educate in a very open forum and provide as many resources as possible to this population. We were finding in our research that there was a lack of studies in undergraduate areas, and we were able to come up with about 90 articles in our database. We also were trying to limit our research to the last 5 years to make it as up to date as possible. We did reference some landmark studies from the 90s about mental health, which is pretty common, but for the most part, we were able to stick to the most recent. And we also noted that there was a lot of the need for research in Pennsylvania because a lot of the data was from another state that we were able to find. So that leads us to our PICO question, which if you don't know, PICO stands for Population, Intervention, Comparison, Outcome, and Time. So this was our overarching statement that we were looking to study and accomplish. So the focus of this study is in undergraduate students 18 and older at Carlow University. What is the effect of evidence-based education regarding mental health recognition, stigmas, and health-seeking behaviors on mental health literacy scores before and after receiving educational information from January of this year until March of this year. Okay, so for our materials, we did a 13-point Likert questionnaire, which we presented as a pre-test and then also a post-test. We did a 10-slide PowerPoint presentation as our educational intervention, and then we took demographics, which we didn't go too in depth, but we did do age and gender. And then our participants were just taken by a convenient sample of undergraduates that were 18 and older. So we did a mixed methods research design. We collected qualitative and quantitative data. And our questionnaire, like we said, was a 13-point Likert scale that we measured pre and post. It was derived from a 35-point mental health literacy scale, but to make it easier, a different study that we had looked at actually made it into a smaller scale, which was 13 points. So we delivered this pre and post test electronically via Google form, and they just filled it out on their personal devices. And then we used unique identifiers to be able to correlate the data.
Our final sample consisted of 26 participants, 24 were females and 2 were males, and we had an average age of 20.58 years. So our mental health literacy questionnaire assessed the knowledge of mental health seeking behaviors along with resources and service that the students had access to, and then their willingness to actually receive these measures that they had available to them. And then we also discussed in detail the stigmas regarding mental illness. So the Likert scale utilized a scale that ranged from 1, which was strongly disagree, to 5 that was strongly agree. And we had items that were also reverse scored on this scale. So our educational PowerPoint really hammered in the points that were presented in the health literacy scale itself to be able to adequately improve their scores in addition to educate them the way that we needed to. And for that, we used a Wilcox signed rank test that was a non-parametric version of a paired t-test. So this is our actual scale that we use. As you can see, it looks at, are we confident where we're seeking information? Do we know how to reach resources via telephone? Do we feel comfortable going in person, speaking to someone about mental illness? Then we look at the stigmas more so of, is mental illness a sign of weakness to you? Is this a real illness, or is it all in your head and you can snap out of it? So this is what the scale measured. This is the pre and the post test that was actually administered to the individuals. So for our results, we had a p-value of 0.01, which if you guys aren't familiar with statistics, that is statistically significant. And that was the significance between our pre and post average scores. Undergraduates can improve mental health literacy via a PowerPoint presentation. So we did prove our PICO question to be adequate. And then there's just a little breakdown of the actual math of our research.
So now we can look at the implications and conclusions of our study. So as the last slide showed, all scores were improved from the pre-test to the post-test. Participants were able to seek out mental health resources. And then it also showed increased confidence in appointments with healthcare providers. We were able to show that there was a decrease in stigmas from like the pre and the post-test. And then willingness to seek treatment was also improved. So some more strengths of the study: comprehensive research suggesting need for the project. As we mentioned, we were able to find about 90 articles, and it did show that this population was warranted to study. Other than that, another strength, we did do a live presentation in PowerPoint for our participants. We were able to provide evidence-based and college-specific educational information. And then, so our educational presentation proved to be effective. So limitations of our study, there is a possibility that there was a sample error just due to the convenience sample. And then there was also a lack of male subjects. Like we said, there was only 2 males. And then there was a small sample size. So in conclusion, our research, it did prove efficacy of short evidence-based presentations on mental illnesses in college students to improve mental health literacy scores. It is also a very sustainable intervention. It does not require copious amounts of time. It also doesn't require like a lot of resources. And then it also is adaptable. So if you wanted to give this presentation to someone other than like a college population, you could definitely do that. So yeah, it was very easy to perform and beneficial. So lastly, we would like to thank a few people for making this possible. So Dr. Ruth Foreman, Dr. Beth Zamboni, Dr. Deborah Mitchum, Tina King, the Carlow Center of Health and Wellness, and the Carlow Counseling Services for helping to make this project possible. Lastly, we would like to thank you, the audience, for your attention, and we invite any questions at this time.
I have a question. How were you able to get your, so who were the participants? Like, how was your access to the participants? Was it through like the counseling services or?
So we actually used Dr. Zamboni's statistics class. So it was a general math class. So we got the population that we needed. We were expecting to have some more participants than we had with the class sizes, but it just didn't pan out that way. So in the future, if we were to broaden this study, we would definitely do a larger sample size. And it would be really nice to launch it university-wide, but that's easier said than done. We did find it's really important, so.
To mention as well, we did get IRB approval for this, and that involved informed consent. So they were able to opt out of the study too. So it would be nice to be able to do this on a larger scale to really get some more data as well. But it was nice that we had the sample size that was a general course. We got a lot of different majors. We didn't want to just focus on nursing because that is an area that they probably do have some more access to mental health sources. So that's why this was our convenient sample was supplied that way.
It's a really great topic. I mean, it's definitely a needed topic, as you said, so it would be nice to see it on a larger sample. Again, you know, you have to watch sample size. My comment is to, whenever you're writing up conclusions, is to ensure that you're not writing that you've proven something, but to ensure that you've demonstrated some causality or association or correlations. You just have to watch some of that when you're with your results. I think your message is clear with what you showed, but you just want to be cautious with that.
Do you have ways or apply this to your practice? Is this important enough to you that you want to implement this in some way to your own patients? Was it passion? Did it become a passion for you? And as you demonstrate, important?
I think definitely, obviously mental health is a hot topic right now with just everyone in general, especially with the pandemic. We've seen a lot of increases in mental health issues. So I think this could easily be applied to any patient, just like we would do the PHQ-9, the PHQ-2 for depression on our patients. You know, it's a quick 2-question questionnaire. We could always have this as part of the intake paperwork just to see where they're at. Because I feel like when we did our education, a lot of students seemed very surprised on how a visit would go for a practitioner, whenever you were addressing a mental health issue. I think we really eased their minds on reaching out is a comforting, practice. It's not meant to be scary. You know, providers are very understanding of mental health issues. So I do think that this would be, you could implement this anywhere, but especially primary care because you see every type of population.
I think it's also really important to always be aware of the resources that we have as primary care providers and where to refer our patients. Like, yes, we can absolutely start them on an SSRI. However, it is most important, especially with anxiety, to get them into behavioral therapy. So that is something that I worked a lot with my preceptor. I feel like we had a lot of positive PHQ-2s and PHQ-9s, and we were diagnosing a lot of people with depression and anxiety. And so we ended up always starting them on a medication, but then in addition to that, we were always referring them to behavioral health. And we were making sure that they followed up on that, because that's where we lost people. People do not always take the steps to go to the behavioral health therapist. And so we tried to do some frequent follow-up with that. And I think it's important to know your resources, where to send them, and to follow up. So that's a major takeaway I had. Although we were working with Carlow undergraduates and giving them their resources here on campus, it's important to know that in your own practice.
You know, I was going to say that it would be very interesting to follow up to this. You know, so how many of the students that you or your participants ended up seeking counseling?
Yeah, that would be interesting. And I think a lot of them didn't even know it existed, to be honest with
Yeah,
you.
so there would be that, yes, and then there would be the acceptability of it, right? But it would be a very, very, very interesting follow-up.
Exactly.
Okay, thank you. So we just need a couple minutes to chit chat. Thanks.
No, I honestly just stand up to
You forced me. I should have just been like sitting all the people.
You could have been able to get one. I think I know.
Very confident.
Yeah.
That's what doctors.
It's like a good vibe, yeah. It's a love. I have this. Oh, that's cute.
No, everyone got it, except for you got pearls, and the guys have prizes. The guys is the same, Bobby's is the same.
So you guys got
Yeah.
this is
I was like, that's not
Hi, nice to meet you. I've heard about you.
Yeah. All these Ohio girls.
I know, I didn't know. No, from Akron. He's in the short one now, but it's
I told Trevor not to bother to coming back in. I'm like, they're gonna miss it.
What's that? I'm Dan, nice to meet you.
So my mom. And my wife was.
You have a random UA, did you UA?
They did when I went to the,
Okay.
I can think of. How high is your weight?
I didn't have it.
I get full stress kidding. Yeah, I think so.
Like it's fine.
It makes me feel like
Oh, no, I was very concerned.
Did everybody get a bag?
I'll take that. I'll make it.
Okay, and so everybody did such a wonderful job. This was a really, really hard decision to pick, but we have 3 prizes for first, second, and third place for presentations tonight. And we had not just the faculty that's in the room, but we had all the other Roman faculty completing, evaluations of your work. And, we're all really impressed, really impressed. You did a great job. You were a great class. You can be very, very proud, I think, of all that you've accomplished as scholars, in addition to the awesome nurse practitioners you're being. What can I say? We're gonna have one more event before we part with you, but tonight I just want to announce that our unanimous decision was that the first prize would go to the students who studied the effectiveness of motivational visual content on smoking cessation. Bethany Frame, Sarah Tapp, and Catherine Henderson. Second prize is for the students whose title I didn't write down. But they include Derek Hansen, Kevin Jackson, and Cameron Zahanka. Second prize.
It's a collective, and so as you're already a team, you're gonna be shimmer.
And last but not least, the third prize to Andrea, Carroll, Morgan, Fisher, and Savanna Gongloff for assessing mental health literacy in college students. And I also want to announce tonight that there are a couple of Rose Kern Awards. Have those of you who are recipients been notified of that, which would be a scholars night next week. And then we did nominate as faculty Morgan Fisher for outstanding graduates. And we also nominated Rashay Giles Mitchell, who graduated in fall. So this was all this year's graduates. And the award was actually given to a doctoral student. And Rashay Giles Mitchell received an honorable mention, for which she'll receive $250. So that's how good. And this is the first time that the president has decided to give that award. So, yay to Morgan. And because, for all that you do and for all that, your work that was so deserving of that nomination. Congratulations. Okay, so